Great. Good afternoon, everyone. My name is Dr. Rob Murphy. I'm the Executive Director here at the Havey Institute for Global Health. I'm the John Philip Fair Professor of Infectious Diseases and Professor of Biomedical Engineering and Medicine at Northwestern University. Thank you for joining us this afternoon for our latest installment of the Havey Institute for Global Health seminar series. Today's presentation is entitled Investment in Capacity Building and Research Development as a Catalyst for Sustainable Development, the Success Story of Northwestern University and University of Ibadan Partnership. Please take a moment to follow us on Facebook, as well as Twitter and Instagram at #FSM Global Health. There, we share Institute opportunities, photos, news, including links to our latest Explore Global Health with Rob Murphy podcasts. The most recent one was Balancing a Career in Global Health with Shannon Galvin, MD, one of our faculty members here. And Shannon is also the new director for the Global Clinical Outreach program that we have. We also welcome you to become an Institute member, where you will receive access to specialized resources and services that support research infrastructure. For more information, please visit our website at globalhealth.northwestern.edu/members. Very easy to sign up. Today, we are thrilled to host my great friend and colleague, Professor Isaac Adewole, for this seminar event. Professor Adewole is the immediate past Minister of Health for the country of Nigeria. He's also the former Vice Chancellor at the University of Ibadan in Nigeria and former President of the African Organization for Research Training in Cancer. He is also the co-founder of the African Cancer Coalition and a member of the International Taskforce on Elimination of Cervical Cancer in the Commonwealth. Professor Adewole is a global health expert and leader. He has led several research projects on prevention, diagnosis, and capacity building on cervical cancer in Nigeria and sub-Saharan Africa. He's authored over 250 publications on topics such as cervical cancer, sexual and reproductive health and rights, abortion, HIV, and human papillomavirus. There will be some time for questions following the presentations, but because of the size of the audience, we ask you to put your questions through the Q&A feature at the bottom of your Zoom screen. Don't put it in the chat box, please. Put it in the Q&A part. And I will be asking Professor Adewole the questions that get put in there. And now, Professor Adewole, I turn it over to you. And thank you very much for joining us here today.
Thank you so much, Rob.
Can you share? You have to share your screen now.
That's what I'm trying to do now.
Oh,
Can you see it?
Not yet.
Not yet.
We were just practicing this. Supposedly it worked.
I did it a few minutes before we started.
Meg, any advice here?
No, Professor Adewole, do you remember what you, because we were just practicing and it worked perfectly.
It is.
It did. Do you remember when we were practicing? Are you able to pull it up? If you can just pull it up, then you can screen share.
I'll get it.
If you're able to just pull.
Still not showing.
You have a copy of his slides, Megan?
No. So sorry, everyone. One moment, technical difficulties.
I'll sort it out now.
Professor Adewole, if you'd like to send me the slides, I am happy to share from my screen.
Okay,
Or if you're
I'll do
able to
that.
just, if you're able to pull up the slides or the presentation itself, then we could see if it's the share. Folks, thank you so much for the patience. We were just doing this and it was perfect.
Yeah,
But technology sometimes.
I checked it before we started, and it worked
And it
perfectly
was
well.
perfect.
I think, let me just send it to you.
There. It's up.
We've
Did
done
you see-
it.
Yeah, it's up there.
Yes. Thank you so much, everyone. Thank you so much for your patience and for your
Is it
understanding of
up?
technology.
Yeah.
Oh my God.
It is up and
It-
it's looking great.
and it's moving. Is it
Yeah.
moving?
Yes, it's
It is,
moving.
it is
Thank you.
moving. It looks perfect.
Sorry.
Okay.
Yes,
We're in business.
yes, we are in business. Thank you, Rob, for the kind invitation for the Institute, asking me to make a presentation. I'm not new to the Institute, and I want to thank you for our partnership, which is been in place for over 20 years. Today, I'll be looking at the partnership that we built over the last 20 years and what it has done, and how we can use it to address the human capacity challenges that we face in Africa. I've done my declaration. You've actually addressed that in the intro, and I want to thank the Institute. Thank you, Rob, for the opportunity, and also thank Phyllis, who actually kick-started our relationship, Lifang, and my colleague now, who is keeping the flag flying in Ibadan, Professor Moasimbelo. This presentation is being dedicated to Rob Murphy and about 24 years of relationship that we've nurtured. And that relationship is blossoming and growing by the day. This is Rob Murphy, Lifang, at my Sentford program in Ibadan on May 5. This is also Rob and Lifang in Ibadan. Rob and Murphy with Phyllis Kanki and Moasimbelo and my wife, also in Ibadan, during the twin event that was organized to send me forth. What essentially are we talking about today? Nigeria has a population of 223 million, 274 universities, including 10 medical universities and 54 medical schools. But yet, we face an unprecedented shortage of human resources for health due to immigration, both internal and external. And we've coined a word for this immigration called the Japa syndrome. And it is my proposition today that a reactivation of a homegrown variety of the MEPI program can potentially reverse the Japa syndrome. And I try to look at the Northwestern University of Ibadan training partnership of capacity building and trainer initiative, which we managed over the last 20 years. And I try to look at human research capacity development in health globally in Africa, and also look at the successes that we've achieved over the last 2 decades. The WHO defined human resources for health, also known as human resources for health, HRH, or health workforce, as all people engaged in actions whose primary intent is to enhance positive health outcomes. Human resources for health essentially constitute the most precious of the many resources needed to prevent diseases, cure them when they occur, rehabilitate sufferers, and sustain good health. Their prevention is therefore extremely crucial to their effectiveness and efficiency, which also depend on their dedication, motivation, and commitment. And the task of human resources development for health, therefore, should be a concern to all of us, particularly as educators and trainers, as well as those who plan and provide health services. This was the key of the 25th anniversary lecture delivered by Professor Umaru Shehu, a former WHO country rep, when we celebrated the 25th anniversary of the College of Medicine, University of Ibadan, when I was a provost. What is the goal of human resource development? The goal, essentially, is to get the right workers with the right skills in the right place to do the right things. It's a question of right in 4 places. We must have the right workers, the right motivation, the right capacity. They must be in the right place, and they must do the right thing to get things right. There are 4 or 5 core areas for human resources for health. We need to look at recruitment and staffing. We need to look at compensation and benefits, training and development, talent management, safety, and compliance. In the WHO seminar report, which is titled Working for Health in 2006, WHO explicitly stated that there's a relationship between the quantity of health workers and maternal survivor, child survivor, as well as infant survivor, and that this density of healthcare workers is directly proportional to the probability of survival. Therefore, health workers save lives. Why do we need to invest in health? One, healthier is wealthier, and so people say health is wealth. It is essentially a human rights issue. There's an economic case for investing in health, and that case is robust. And good health is associated, is actually an outcome as well as the foundation for development. And the current DG of the WHO, Tedros Adhanom Ghebreyesus, said investing in health is a political decision. And all of us must take this conscious political decision to invest in health, and that there are individual and population benefits when we invest in health. And when there's increase in life expectancy, we should expect a rise in GDP. And interestingly, of the 7 building blocks, WHO has situated the health workforce as central to the health system building block. When proposals from countries were reviewed for the Global Fund proposals for TB, HIV, and malaria round 5, human resources development was number 1. So it is therefore not surprising that practically all countries prioritize human resource building as critical to health system strengthening. And therefore, the kernel of my discussion today is that human resources are key, they're critical, they're germane to human health system strengthening. In Africa, we have less than 3% of global health workers to address 24% of the global health body. And the Sub-Saharan African Medical School study, the SAM study, indicated that 1/4 of medical graduates, in fact, close to 1/3, leave the country within 5 years. 1/3 of faculty posts are vacant. 30% of faculty must supplement their income. 50% of medical schools are less than 20 years old, and 1/3 of new medical schools are private. Therefore, the private sector has a major role to play in building human capital within the African continent. The Sub-Saharan African challenge here is that even though we have 11% of global population, we contribute 49%, almost half, of maternal mortality globally, about half of under 5 deaths, and about 2/3 of HIV and AIDS. This current crisis is a source of concern to a lot of workers, and therefore it is important that we devise both homegrown and internationally supported strategies for addressing the current crisis in human resources for health in Africa. This is looking at countries with critical shortages of human resources for health, doctors, nurses, and midwives. And when you look at it, essentially, it is the dense red area of sub-Saharan Africa, part of India, part of Bangladesh here, and part of Pakistan, and then Malaysia, Thailand, and then part of Malaysia and Thailand and Philippines. This is also looking at the distribution of the human resources, and you realize that Africa is far from meeting the population, the recommended population, that is global health workforce density that has been recognized prescribed by WHO. And this actually has been described by many workers as wastage of the health workforce. And this wastage can be direct due to migration from health to non-health sector, emigration outside the country or within the continent but outside the country, deaths, and movement to other essential sectors in the economy. And then you have indirect wastage simply because some people may not want to practice in other areas. These have been well documented by quite a number of studies. And then looking at the SAM study, the SAM studies made 10 germane recommendations for building and improving the human resource capacity in Africa. And these will include from looking at strengthening the medical schools, the faculty, recruitment and training, down to revitalizing the African Medical Association. These 10 recommendations are quite germane to improving the human resource situation in Africa. This is also looking at the location of graduates within 5 years of leaving the medical school. When you look at this, almost 30% of them are outside their country within 5 years of graduation. And when a study was conducted in 4 countries, Cameroon, South Africa, Uganda, and Zimbabwe, why do they leave their countries? Number one is poor remuneration. Also, there is also many of them leaving because of security challenges. They want a safer environment. Some are actually looking for better conditions, and some are complaining about lack of facilities. But number one reason for leaving or immigration is better working condition. The exit routes will include migration from home country, that is from rural to urban areas within country or one country to the another, essentially due to risk of violence, illness, or death, change of occupation, and then you could also have retirement. And these have also been extensively studied by quite a number of other workers who actually recommended that countries in sub-Saharan Africa and other fragile settings should prioritize funding human capacity building efforts, strengthening equitable and international, regional, and national partnerships, delivering locally led human resource capacity building programs, ensuring long-term evaluation and implementing these programs, and adopting and engaging interactive approaches, including technology. And this is also looking at retention in Tanzania. Many of them in Tanzania will live from favorable working conditions. Many will leave because they cannot find accommodation and the environment being unsupportive. And then the report also recommended strategies for keeping workers within their countries. WHO thereafter made the recommendation, develop a global policy recommendation for increasing access to health workers in remote and rural areas through improved retention. And these recommendations included targeted admission policies, recruiting students from their locality, locating them within their environment, making sure that we expose undergraduates to various health disciplines, and also make sure that we revise undergraduate and postgraduate curricula, and also design continuing education problems and improve remuneration again. So this is also looking at the categorization of some of these retention strategy, education, regulatory framework, financial incentive, as well as professional and personal support. These problems can be clearly identified as: one, insufficient numbers of faculty staff, general disrepair of campus infrastructure, absence of basic science and clinical faculty members, substantial deficiencies in the laboratories, libraries, classroom, lecture halls, and hostels, and deficit in information technology and also bandwidth. But again, there are opportunities, and these opportunities include North-South, like the relationship between University of Ibadan and Northwestern, South-South partnership between, say, Ibadan and Jos working together, or Ibadan and Lagos working together in order to build partnerships. This is the 10-year action plan developed by WHO from 2006 to 2015, stratifying it into management, education, planning, knowledge and learning, enabling policies, and crisis response. But still with all this, the alarm is that as of 2020, the global workforce stock is deficient, and we face minimum, even in the best of the countries, a deficiency of 10 million health workers by 2030. And therefore, all of us must work together to devise strategies for addressing this deficiency in human resource workforce in order to address the challenges facing attainment of universal health coverage. We also looked at the African Union Priority Recommendation 2013, which actually is titled Abuja +12. And key recommendation is that we need to strengthen Africa's human health resources, among other things, which will include uniting for leadership, generating innovative financing solutions, making smart investment, and leaving no one behind. Despite the recommendation that African countries should allocate a minimum of 15% of their national budget to health, only 6 countries have met that 15%. And these include Liberia, Madagascar, Malawi, Rwanda, Togo, and Zambia. 4 are close to 15%, but the rest are far from 10%. Djibouti, Ethiopia, Lesotho, and Swaziland are close to 15%, but the rest are nowhere near 15%. What are the key recommendations that the WHO policy 10-year investment report made? One is that we need to elevate health as a force for economic growth and societal progress, enhance return on investment in health, increase ownership in key health initiatives, and strengthen economic growth and development. And that we need to unite leadership for health in Africa, generate innovative financing solutions, make smart investment, but much more importantly for today's presentation is that we need to strengthen African human health resources. We need to train more health workers and train them better. We need to encourage South-South knowledge sharing. We need to create more health jobs and retain health workers and leverage new technology. And then, also importantly, leave no one behind. What are the critical challenges that we face? One is the lack of qualified research staff, poor incentive and reward system, infrastructural deficits, funding issues and established support system, and what I've called academia-industry disconnect. This is looking at the work plan lifespan strategy, where we need to balance entry with the workforce with exit and ensure that we optimize workforce performance. It's important that we situate this within a strategic plan to retain the health worker in Africa. And we also need to look critically at the pipeline to generate and recruit the health workforce. And we need to look at the pool of eligibles. We need to look at the training institutions. We need to look at potential workers And how do we then recruit and retain the health workforce? And also reduce attrition and also minimize migration. This is also looking at the relationship between education, labor, and health service market, and they are all intimately related. Education demand, labor supply, labor demand, and demand for services. In other words, education and health must speak together. There must be a handshake, and this is a critical deficit in many of the African institutions. Health hardly speaks with education. In other words, education makes pronouncement, health makes pronouncement, and there's little or no handshake between the two of them. And we also need to look at the various dimensions of health workforce performance in terms of availability, in terms of competence, in terms of responsiveness, and in terms of productivity. All these are essential and are germane to better outcome within the healthcare system. And we need to get it right in terms of the mix. Numbers, diversity, and competencies. All these are quite important. We need to have the appropriate numbers. We need to have enhanced diversity, and we need to have competencies ensured. This is the only way to ensure that the healthcare system in Africa is sustainable and that we move towards attaining universal coverage by 2030. We need to study critically the forces driving the workforce. We need to look at health needs, the health system itself, the context, and look at the challenges that we face, the mix and so on. And then we now need to look at the investment. It is important to see the small dot of Africa compared to the big dot of America, Europe, and in fact, even the Western Pacific. There must be greater investment in health and education in order for us to attain the required percentage of global workforce that would deliver appropriate health to our people. In terms of Nigeria, Nigeria is a unique country of over 200 million people. Few others can rival our industrialness and cultural standing. We are distinctive people. We are the African most populous country. We account for 47% of West African population and over 250 ethnic groups. We have a youthful population with a median age of 17 years, and we love sports. We are the economic powerhouse, and we are a center of trade and industry. And it's also important to appreciate that our large population can be for good or can also be a challenge. And we need to we need to address the demographic challenges that are associated with a youthful population and a large population. In terms of health statistics, we still have a life expectancy of just over 60 years. Malaria is still a major challenge. Child mortality is an issue, and 37% of children 6 to 59 months are stunted, 7% are wasted, and 20% are underweight. And 12% of women aged 15 to are thin, and while 20% are overweight or obese. And the adult mortality rate was at 3.18 deaths per 1,000 population, and 3.25 deaths per 1,000 among men. And this is also looking at the investment in health as a percentage of the budget. When you look at it, even though the Abuja Declaration was signed in Nigeria, even up to 2021 and I dare say up to 2024, we are still far from 10%. We over around 5%. And so when you look at it in terms of budget per citizen healthcare, what we spend in Nigeria is far less than what is appropriated and spent in Egypt, Rwanda, Kenya, and South Africa. And the under 5 health system now has a doctor-patient population of 1 to 5,000, which is almost 10 times the required ratio recommended by the WHO of 1 to 600. Therefore, we still have a large number of work to do in terms of population and also in terms of getting the doctors in the right place. But what is also critical is that the doctors are not well distributed. When you look at FCT, which is Abuja, the total number of doctors in Abuja alone is more than the total number of doctors in the Northwest and the Northeast, where we have serious health challenges. So there is internal maldistribution of the doctors. So within the context of Nigeria, we need to address this maldistribution of doctors, and we need to either do task shifting or offer incentives that will make doctors come to this zone. On the other hand, we've made significant progress over the last 20 years. We've actually moved from the National Health Insurance Scheme to a National Health Insurance Authority. We have launched, enacted the National Health Act, and we've also launched a basic care provision fund to finance primary care. And we're actually reducing infant and maternal mortality rates in the country. So some progress have been made, but we are also saying we can do more. The incentive for this presentation actually came when the Nigerian Minister of Health put out an alarm that over 5,000 Nigerian medical doctors migrated to the UK between 2015 and 2022, and it has not stopped. I looked at the current data, despite the fact that we are turning out a large number of doctors, about 10,000 per year, the number of doctors practicing have actually plateaued. So in other words, Nigeria might be losing about 10,000 doctors out of the country every year, because the number of doctors registered to practice in Nigeria have remained fairly static. So we have a huge challenge to address this JAPA syndrome and also the maldistribution of doctors within the country. I now try to look at what we've done in terms of our relationship with Northwestern, how this has helped to build infrastructure, how this has helped to develop capacity, and how this has helped to retain physicians within the country. And I'm trying to recommend this as a model that we can use to retain doctors and nurses within the Nigerian health system. It is a win-win for all of us. I tried to trace back to about 2000 when we started with APIN, move on to PEPFAR, and that the initial focus was on HIV, with focus on TB, hepatitis, malaria, and we also moved to address prison service, because we got to know that we had a lot of tuberculosis even in the prison service. And through this program, over the years, we built abundant capacity, we've developed infrastructure, we have one of the best laboratories you can find in the country. We build a large retinue of clinicians who are able to practice, and essentially we've been able to retain a large number of them. In other words, this win-win situation can be replicated across board, and it will help us to retain many of our professionals. These are photographs taken over the years. I'm sure Rob will be able to recognize himself there. That's Phyllis Kanki, that's myself, that's Prosper Okonkwo and many of our colleagues. That is also Rob. I'm sure this was taken in Jos. And so this is also part of, this is Jos. And I can recognize Musa there. Sorry. Yes, Musa is there. This is Lifang, and that's also Rob. And this is the AfriHealth conference we had in 2019, and I'm sure we will recognize this gentleman who is in Fogarty and supported us extensively during his time there. So we also have quite a number of training grants, and it's worth mentioning that we had the A-Trip, which focused on HIV in Mali and Nigeria, and we also started the biomedical engineering program, which has now become a standard program for Ibadan. And I'm proud to say that Professor Koka, who is now leading the biomedical engineering program, is kind of proud of this program. And all those who are working in this program are still retained in Nigeria. None of them has emigrated. This is the faculty trip enrichment program, where at least we send one person from Ibadan and one person from Jos. In addition to that, we also instituted the Master in Clinical Science program. And I think at the last count, we've trained about half a dozen people with Masters in Clinical Science program, University of Ibadan. This is the mapping team when they visited Ibadan. And this is the leadership of the University of Ibadan, as well as the MEPI leadership as well. That is Phyllis Kanki, that's Rob Murphy. And this is also Coca that I've mentioned, managing the biomedical engineering program. That's Rob Murphy, and that's myself, and that's Chris Bode, former CMD of Luth, and that is Paula Mountain of Northwestern. All of us at the 100 Change Challenge in Chicago. So what are the outcomes from our biomedical engineering collaboration? We've actually developed a number of gadgets which are relevant to our local setting, in addition to keeping people down because of incentive, because of enhanced opportunity to work and do research. There is the infant warming pad, the needed disposable device, the device for detecting imminent strike through wound dressing, a phototherapy lamp, but medical animal metabolic cage, and also a standard textbook, which is the first of its kind in Africa. These are some of the devices that came from the biomedical engineering group. They now even have a device studio, and I'm sure that working in that studio, quite a number of things will come out of it. It's also important to highlight the contribution of the MEPI Partnership Program, the Medical Education Partnership, which was launched in 2010 as part of a program to support the strategy for increasing the number of health workers in Africa, increasing retention of health workers, and increasing ability to conduct locally relevant research, both HIV and non-HIV related. And this is actually a priority award that lasted for 10 years and took place in quite a number of countries. These are the MEPI countries: Botswana, Ethiopia, Nigeria, South Africa, Tanzania, Kenya, Mozambique, Malawi, and Ghana. And this is MEPI beyond HIV/AIDS. People also looked at other things, considered other priority programs like maternal and child health, mental health, cardiovascular diseases, emergency medicine, surgery, particularly emergency surgery, cancer, and HIV AIDS-related malignancy. And when we looked at what this program has done for us in Nigeria, it did not only promote North-South relationship, it also promoted South-South relationship. We've been able to work between Ibadan, Jos, Zaria, and Lagos. We've been able to work together. And we've engaged over 140 country trainers and offered training to more than 1,600 faculty, which to me is huge. And it is my expectation that a locally homegrown MEPI type program can actually contribute substantially to retention and increasing capacity and quantity of medical educators and service providers in Africa. As I've said, so far, MEPI has trained over 140,000 healthcare workers, strengthening country medical education systems, and build clinical and research capacity in Africa as part of retention strategy for faculty of medical school and clinical professors. Overall, there were 30 regional partners and 20 United States and foreign collaborators. And 3 universities in Nigeria played major role, particularly Jos, Lagos, and Ibadan. And we trained over 5,000 junior faculty in a 12-year run. And in total, I said we have trained over 1,000 junior investigators and closely monitored more than 50 others. This is looking at national health policy, which we formulated while I was in office. This happened to be the 3rd national health policy in Nigeria. And we also critically identify a major need to address the human resources for health in Nigeria. So it is quite germane that we focus on this and also address the maldistribution. When you look at the density for North Central, 9.7%, for Northeast, 4.3%, Northwest, 8.3%, Southeast, 19.6%, South-South, 14.3%, and Southwest, 43.9%, and that includes Lagos. In other words, about 4 out of 10 doctors in Nigeria are located in the Southwest axis. So there is a lot of maldistribution. And therefore, a new focus would be how do we ensure that we serve these underserved communities and ensure that no one is left behind. Currently, we have moved on to new terrain, and I want to appreciate Rob Murphy, Lee Fang-Hu, that we've been able to break new grounds. We're training new cadre of people, and this will further ensure retention because you are going to achieve job satisfaction. We are going to build research capacity. We are going to improve remuneration. We are going to increase satisfaction. And there are 3 currently ongoing projects that we're handling. That is the EPOC project, which is the epigenetics of oral HPV and associated oral and oropharyngeal cancer in people living with HIV in Nigeria. Essentially, we seek to understand the epidemiology of HPV-associated oral and oropharyngeal cancers among our people. And we also want to look at the trajectory. We want to study the morphology, the anatomy, and the behavior of this cancer, particularly in people living with HIV, and also those who do not have HIV. This study is essentially being located in Ibadan, but then we are functioning in 12 satellite sites located in at least 6 states in the country. The other study which we are currently doing is the West Africa self-sampling HPV-based cervical cancer control program, which interestingly we are called the WATCH study. And what we're trying to do with this study is to look at how do we promote acceptability of self-sampling? How do we improve testing? How do we improve screening for cervical cancer? Because we know that there are 2 main strategies for addressing cervical cancer. One is vaccination, the other one is screening. So how do we improve screening? How do we encourage women to screen? And we're trying to look at acceptability. We're looking at how do we motivate our women to do self-screening. And we're quite convinced that the result from these 2 main studies will change the dynamics in terms of how we manage oral and oropharyngeal cancer, and also how we manage cervical cancer, and how we prevent them in Nigeria. And the 3rd one, which is the BCAR project, is looking at the epigenome biomarkers of anal high-risk human papilloma infection in women with cervical high-risk human papilloma virus infection. And this is a project that is being undertaken by Professor Imran Masibelo. In Ibadan, these 2 studies are being led by Professor Masibelo, and I want to say I'm extremely proud of him, and he's actually carrying the flag flying, and we're quite sure that with him leading the group now, the sky is not the limit, but the beginning. In terms of what we've been able to do, that is the design of the EPOC study. As I've said, we're looking at people with HIV and people without HIV, and it's a longitudinal study that will last for 4 years, and we've actually started recruitment. In addition to recruitment, we will also study them. They will do follow-up visit every 6 months over a 4-year period. This is the work study, which is building on a partnership of at least 15 years, if not 20. This is looking at, we are building on Rob Murphy's long-term relationship with Mali and also Nigeria. So we are working in Mali, 2 sites in Mali and 2 sites in Nigeria. And we're leveraging on this relationship, and we are looking at how do we conduct quantitative as well as qualitative studies. And we're training people, training 11 persons to conduct qualitative studies. 2 persons have been trained on coding and analysis, 3 doctors on digital colposcopy, and 4 nurses on counseling and self-sampling. and 4 persons on RECAP. So all these studies are not just being done for study's sake, for research sake alone, but we're also building capacity. And it is our belief that we'll be contributing essentially to the human resource pool in Nigeria and beyond. We've also taken custody of quite a number of new equipment, the Attila machine, the telepathology microscope machine that will be handled by Professor Femi Ogumbi. And this is the Vescope that we'll be using for the EPOC study. This is the thermal ablation machine and the corpuscope that we'll also be using for the watch study. And in all of this, we're now building an HPV research consortium in Ibadan that will be looking essentially into clinical, basic, and medical, as well as public health and dental school. We're bringing together a large pool of people to work together. We're looking at different aspects of HPV, knowing full well that HPV goes beyond the genital area. The Shini study done by Professor Masimbelo has convinced us beyond doubt that that HPV is something we have to look for beyond the genital area. We have to look at inner, we have to look at the oral and pharyngeal spaces in order to develop proper algorithm for managing these cases. And we believe that at the end of the study, this research consortium will not only train, but will contribute essentially to building human research capacity in Nigeria and also building a research infrastructure in the country. Are there lessons for a partnership? Essentially, this is a North-South partnership that has also engendered a South-South partnership. As I mentioned earlier on, we have worked between Ibadan and Jos and Ibadan and Lagos and between Jos and Lagos. So 3 institutions are working together in a robust partnership. For the EPOC study, Ibadan is actually working with 12 other sites in 6 states in the country. We are building capacity. We are doing infrastructural upgrade. There is incentive. We are contributing to retention. We are contributing to career upgrade because we've actually generated a number of publications. But what we've also learned is that success takes time. We're looking at a relationship now that has been in existence for over 20 years. So success takes time. And that's one of the key lessons we've learned from a partnership, is that there is no shortcut to hard work. And again, hard work pays. My take-home messages is that investment in research is directly linked to national development, and that research generates and advanced frontiers of knowledge, skills, innovation, discovery, training, and expertise, as it is the bedrock of economic development and improved living conditions in the society. Capacity building in research activates innovation and discovery and potentiates opportunities for sustainable development. In addition, genuine partnership and collaboration in a transparent and equitable way foster development, as shown in many decades of engagement with the Northwestern University. Active engagement in cutting-edge research by Nigerians is now a reality, as we have shown in Ibadan. This is looking at the average budgetary allocation and spending in health and education. When you look at this, Nigeria is even far from Ghana. We currently have averaging 5.8% allocation to education, 4.2% to health, compared to Ghana, 23% to education, 18.5% to health, and US 15% to education, 28% to health, and UK 13.5% to education, 22.5%. And I said Nigeria must invest in health and education. We need to invest in human capital development for our country to break forth and for our country to achieve sustainable development. And that we need to understand properly the framework for getting this done. We need to do the situational analysis, balance policy with leadership, finance, education, and partnership, and look at implementation and how this can influence health and how we can make sure that all the critical elements that are genuine to having health are in place. And also, these can then lead to population health needs and better outcomes on this side. And this is important. We must not only spend money, we must spend money to achieve better health outcomes. And it is by so doing that we can beat our chest that we've done well for our country and for Africa. I want to thank you for listening. And once again, I want to thank Rob Murphy, Lee Fangu, and all our colleagues at the Havey Institute for Global Health for the opportunity to make this presentation. Thank you.
Thank you very much, Isaac. That was a great presentation, and it's so wonderful to see the progress that has been made over the last, in particular, 20 years. Really just absolutely remarkable, and you were so instrumental in your leadership roles and your scientific knowledge to push all this forward. It's been such a great pleasure working with you. We do have a couple minutes for questions. Please put your questions in the Q&A box located at the bottom of your screen. Until I see one in there, I'm going to ask you a couple, okay? A little background that I think a lot of people don't appreciate is the population growth in Africa that's expected over the next several decades is really going to be astronomical. The population is going to more than double by 2050 is my understanding, whereas all the other continents are flat or going down, mostly going down. How improving the health infrastructure is, of course, critical. Where does the private sector come into play in the progress that you're hoping for in Nigeria? Besides just the government programs, you have all the Catholic Relief Service and the the other private hospitals there. Where do you see that fitting in?
Well, thank you, Rob. There are two aspects to your question. One is the population trajectory. And I quite agree with you that is worrisome. Nigeria, by 2050, will probably become the third or fourth most populous country in the world if we do nothing. And therefore, the issue of population control is something that is of topmost priority. And at least for once, let me say clearly that we are now discussing it more openly than we used to be, even at government level. Before, I think government leaders will be shy to discuss about the population growth. Now people are talking about it. With respect to the private sector, I believe that the private sector will play a major role over time in building human resource capacity, in shaping the way things will go in many of our countries in Africa. For example, in Nigeria, we now have more private universities than public universities. Mm. Even though the number of students they have might not be as many as that of public universities. But in terms of actual number, we have more private universities. We now have many private medical universities in Nigeria, which never existed in the past. So I think over time, things will change, but we also need to change the funding dynamics. Like many of the funding organs in the country will not fund them, not even for research. And what we are saying is that even if we do not fund them directly, we can fund them in partnership with established institutions. There is absolutely no reason why somebody in, say, Afe Babalola University, which interestingly is one of the best private universities in the country, why workers there or researchers there cannot partner with researchers in University of Ibadan and get funded to do cutting-edge research. I think we could start from that and build trust. The issue is trust. And so over time, I think we'll get there.
We have a couple questions here. One, one from Lisa Hirschhorn. Many thanks for the great talk and partnership. How do we build not just the researchers, but the appetite and the demand for research by policymakers and politicians?
Well, I think that's something that we're doing with the implementation research. We are now saying we shouldn't just do research for research alone, and we need to do research that will impact on policy and practice, and also change the way we live and the way we do business. Interestingly, during my Cervical program, Professor Masimbelo presented to the two ministers of health who were in attendance a brief outline of the work that we're doing. Interestingly, the minister then said, "Oh, I would love to receive this presentation in Abuja." So I think we're already creating some openings for what I would call cross-fertilization of ideas between the research institutions and leaders in government. Because research that is not influencing policy, to me, is not what we need in Africa or in Nigeria. We need to get it across. And I quite agree with that question. We need to move forward and also fund implementation research. The other bit is that some of this money must come from within. I'm one of those who believe that he who pays the piper will dictate the tune. So we need to get some of these initiatives funded locally.
A couple quick questions, I think, here before we wrap it up. In a country like Nigeria with less than 5% budgetary allocation for healthcare, where medical teachers are paid less than a doctor practitioner and research funding is non-existent, which is debatable, how can we make progress? What's the big take home?
That is essentially the kernel of my presentation, that we need to link and encourage more people to do research grants, to get research grants, write research proposals, and we need to do partnership. We need to do twinning. If people are doing well in Ibadan, there's absolutely no reason why we cannot partner with Jos, with Sokoto, and Kano. We need to work together. And this is already happening. It is by so doing that we can co-develop capacities. The amount of resources that are out there are huge, but no one will trust you if you are starting afresh, but you can partner with other institutions. And I would recommend those form of partnership.
One last question, because we're running out of time here. I'm sorry I won't be able to get to all the questions. Thank you for the presentation. What is your opinion on the role of task shifting and sharing in addressing the human resources gap?
I'm absolutely for it. I actually initiated the task shifting policy of the Federal Ministry of Health, and I believe there is a role for other non-doctors, health sector actors to play a major role in delivering care, but they must be trained. They must not only be trained, they must be supervised. So those two key factors are important, training and supervision. We must not just leave them and abandon them.
Great. I'm sorry we're out of time. I won't be able to get to the last question. I want to thank Isaac Adewole for taking the time to share his insight and expertise with us today. We really, really appreciate it. I want to thank the audience for your questions and for being here today. We invite you to join our next Institute for Global Health seminar, which is Wednesday, September 11th. More details on that event will be shared soon. We're also excited to announce our October seminar, which will be in person in the Simpson Query Auditorium on Wednesday, October 2nd, and will feature Patty Gravitt from the NCI, Implementation and Cancer Health Disparities Research at the NCI Center for Global Health, Equity, Collaboration, and Impact. It's co-sponsored by the Robert H. Lurie Comprehensive Cancer Center, and you can register via the QR code here, our newsletter, or social media pages. And again, thank you very much for joining us today. A recording of this webinar will be available online and will be shared via our newsletter. And this concludes today's webinar. Thank you again, Isaac, for joining us today. We really, really appreciate it. It's been wonderful
you.
working with you over all these years. Thank you all.